Panel. Start by recognizing the folks from the VA that are trying to make this electronic health record work to deliver for our veterans under what I see as pretty difficult circumstances. We spent about $10 million on this project so far. New EHR has been deployed to 5 hospitals, 22 community-based outpatient clinics, being used by about 10,000 employees, which sounds big, but in a system as big as the VA, it's not where we need to be. By the VA's own admissions, OIG and GAO reports and independent industry analysts, it is clear that the tools in the Oracle system are not working, at least not working as they're intended to. There's been a number of screw-ups, lack of coordination between DoD and the VA. Within the VA, we've seen a lack of clear goals and strategy and unstable, inconsistent leadership. And while the contractors have been, what I believe, abusing the taxpayers, we know the previous administration didn't do veterans any favors by issuing a $10 billion no-bid sole source contract that needs to be renegotiated, which I'll talk about in a second. Today, we need to hear from GAO that in almost every part of this contract certainly hasn't lived up to my expectations, and I doubt anybody else's either. For all the documented system crashes, incomplete technology, and poor training programs, Oracle Cerner has refunded the government about $325,100 of the $4.4 billion it has been paid through its contract. Make no mistake about it, we need to right the ship. And for me, all options but one are on the table to fix this new EHR. I'm not going to ban the effort to modernize VA's health records. This is not in the cards. It's not sustainable to do. And quite frankly, our veterans need it. And that's why we need to work together on a bipartisan basis to get this program and contract working for our veterans, VA medical personnel, and the American taxpayer. And while the VA has shown some signs of making necessary steps getting to this program back on track in recent months with the help of some of the leaders here today, the following really needs to happen. The Secretary must bring together government and industry best contract experts and renegotiate the Oracle Cerner contract that is due to expire on May 16th. And we need tougher teams, discounting prices, and a narrow set of tasks for Oracle, and severe penalties for poor performance. And if Oracle won't agree to those terms, then the VA should be prepared to roll up the sleeves and negotiate an entirely new contract or find a different team of partners. Just yesterday, VA informed Congress that at least 6 additional veterans have been connected in some way to their care as delivered by Oracle Cerner system, 4 of them fatally harmed. This is serious as our work on this committee needs our full attention and to get this back on track. It's going to be an interesting hearing today. We need to know exactly where the hell we're at and where we're going and what it's going to cost and when we can look for a timely delivery of a thing that we've been talking about here for 20 years. We've all got to step up the table. Over to you, Senator Moran.
Chairman, we're here again to discuss the challenges of the VA Electronic Health Records Modernization Program. I emphasize the word again. We've done this numerous times. The VA aims to create a unified health record for service members and veterans, enabling more consistent health care. It's frustrating that the opposite has happened. The 5 medical centers that are using this system are struggling with delays, disruptions, and rising costs, and only yesterday we find out the system has been a factor in the loss of veterans' lives. We all have concerns about the VA's ability to manage this program, and that's not new. These delays and disruptions, the rising costs, have had unintended but unacceptable impacts to the health of veterans and the programs that were created to serve them. The VA and Oracle Cerner are making improvements, but they are gradual, and many of the most expensive, extensive, and most significant fixes are many months or even years away. Meanwhile, the VA tells us that they will begin rolling out EHR to new facilities in June, which is just around the corner. I've yet to see what has fundamentally changed in the system, training or program management, that will make the implementation more successful. The changes in and lack of current programmatic leadership suggests to me that the whole effort may be sleepwalking toward an extremely destructive result. And due to changes in leadership at the VA, it is still an open question who will be leading this program 3 months from now. To justify additional spending on this program, we need assurances that every penny is spent focused on creating and implementing a system that serves veterans and provides them with the high-quality care they deserve. I need to know if the VA still wants and believes in this program. I need to know what will be different this time under the next group of leaders. Mr. Chairman, thank you for your attention to this issue. I look forward to its discussion today.
Thank you, Senator Moran. I want to associate myself with your remarks. I think they were very much spot on. Today, we're going to hear from key VA leaders that are critical to this program's success, as well as representatives from the GAO and Oracle Cerner. From the VA, we have Dr. Neil Evans, who is the Acting Program Executive Director of EHRM Integration Office. Dr. Evans, I believe you've been on the job for about 3 weeks. But like I said earlier, we've been at this for 20 years, and you still, and you've been at the VA, I'm sorry, for 20 years, and you still provide the care to veterans at the local DC VA hospital. Thank you for that. Thank you for willingness to serve. And you are accompanied by Dr. Sharif Elnahal, somebody who's very familiar to this committee, Undersecretary for Health of the VA. Big job. Kurt Delbenny, somebody that is Assistant Secretary for Information Technology and Chief Information Officer. And Michael Parrish is Chief Acquisition Officer and Principal Executive Director, Office of Acquisition, Logistics, and Construction. I believe, Dr. Evans, you're going to do the speaking for the trio and yourself, and you have the floor.
Thank you. Chairman Tester, Ranking Member Moran, and distinguished members of the committee, thank you for this opportunity to testify in support of VA's initiative to modernize its electronic health record system. Before I get started, I do want to express my gratitude to Congress and to this committee for your commitment to serving veterans with excellence, and specifically for your interest in and oversight of this project. As you mentioned, today I'm accompanied by my VA colleagues, Dr. Sharif Elnahal, Undersecretary for Health, Mr. Kurt Delbenny, Assistant Secretary for Information and Technology and Chief Information Officer, and Mr. Michael Parrish, Principal Executive Director for the Office of Acquisitions, Logistics, and Construction. The representation on this panel is indicative of VA's department-wide approach to its EHR modernization program and our shared desire to get this right. As the newest member of this team, having stepped into my current role, as you mentioned, less than 3 weeks ago, I greatly appreciate the opportunity that I will have to collaborate with these experts, with the teams that they lead, with our contracted partners in this effort, and most importantly, with the frontline VA staff, who will depend on a modernized electronic health record to provide high-quality, responsive health care to the veterans that they serve. Though I may be new to my current role, I am not new to this effort, having been a participant in this project from various vantage points across its lifespan to date. And I would add that I'm also a future user of this system as a practicing VA primary care provider. This matters to me. As you're well aware, nearly 5 years ago, VA began in earnest its journey to implement a new electronic health record, or EHR, replacing the EHR components of VA's VISTA system that has served us well for upwards of 40 years. Our electronic health record modernization effort involves deploying across VA the very same commercial electronic record system provided by Oracle Cerner that is being implemented by the Department of Defense and the United States Coast Guard. As a brief aside, electronic health record systems, as you know, are far more complicated than the name might imply. They are much more than a record alone. They consist of many orchestrated IT capabilities that power clinical care delivery in the modern healthcare system, including care in outpatient clinics, hospital wards, emergency departments, operating rooms, clinical laboratories, intensive care units, pharmacies, radiologic suites, etc. These systems in many ways drive how healthcare is delivered, how work gets done, how patient care encounters are orchestrated, how communication and handoffs occur, and how both patients and healthcare providers access the data that they need for decision-making and more. These systems are extremely complex, and they need to be highly reliable, available, and performant at all times. Transitioning from one set of EHR technologies to another is always a massive endeavor, one that is time-consuming, disruptive, and challenging. Mature organizations also recognize that EHR transitions are more than just a technology change-out. They are opportunities to rethink the people and process side of healthcare delivery, opportunities to standardize and optimize how work is done across the enterprise. Where are we now in VA on our EHR modernization journey? We acknowledge that there have been challenges with our efforts to date. As we work through the challenges, our commitment remains unwavering to provide world-class patient care and prioritize patient safety for the veterans we served. We've learned a lot since our initial go-live at the Man Grandstaff VA Medical Center, and in 2022, we completed 4 further deployments in Walla Walla, Washington, Columbus, Ohio, Roseburg, Oregon, and White City, Oregon. And as you mentioned, the system is now in use at 5 VA medical centers, 22 community clinics, 52 remote sites by more than 10,000 VA medical personnel. VA is working aggressively to address issues with the configuration and performance of the new system, based on direct feedback from end users. We expect the same aggressive attention from Oracle Cerner. In October 2022, VA announced it would delay upcoming deployments to concentrate on assessing concerns that have been raised with the system and to develop solutions for the most impactful and critical issues, particularly those with the potential to affect patient safety. Though there is still a lot of work to do, important progress is being made. For example, last month's update to the system included 3 critical pharmacy enhancements, with more on the way. We have addressed usability issues and enhanced training regarding order management in the system, and more. In terms of system stability, this has also improved. As of this month, it's been more than 200 days, or 6 months, without a complete outage. System incident free time, or the amount of time without users experiencing any disruption in their use of the system, isn't yet at its goal, though it is moving in the right direction. As improvements continue to be made over the next months, VA will continually evaluate the readiness of upcoming deployment sites, as well as the EHR system itself, to ensure success. It's important to take the time now to get things right, to provide a strong foundation for an accelerated deployment schedule later as the project proceeds. A modern electronic health record, one that enhances the efficiency of care delivery, one that delivers interoperable health data, one that provides effective clinical decision support, one that serves as a springboard for future integrations and innovation. This is what is required to support the VA healthcare system of the future. Chairman Tester, Ranking Member Moran, and members of the committee, thank you again for the opportunity to testify today and for all that you do to continue to support our nation's veterans and their caregivers.
Thank you for your statement, Dr. Evans. I appreciate it very, very much, and I appreciate you, your commitment to our veterans throughout your professional life. Next, we have Executive Vice President Oracle, Mike Cecilia. Mike is also familiar to this committee. I like to say Mike is where the buck stops. I think that's correct when it comes to Oracle in this system. Hope we get a head nod for that. You have the floor, Mike.
Chairman Tester, Ranking Member Moran, and members of the committee, thank you for inviting me here today. When I last testified before you, Oracle was just over a month into its acquisition of Cerner. I made several commitments about adding resources, bringing new engineering and technical expertise, and making VA's EHRM program Oracle's most important priority. Since then, we have done that and delivered significant improvements in a short amount of time. The technical fixes we have made to the system have resulted in meeting the 99.9% availability requirement in 5 of the last 6 months. Average downtime minutes dropped from 345 minutes per month prior to the acquisition to 21 minutes per month in January and February. The goal of every system should, of course, be as close to 0 as is possible, and we're marching towards that. End users should also be feeling a notable difference across key workflows, with 28 improvements delivered in the most recent Block 8 update in February. We also delivered the top 3 pharmacy enhancements in 4 months, instead of the originally estimated 3 years, as I promised we would do last July. In August, we provided updates for the unknown queue, and now, on average, only 1 order per site per day enters the queue, which represents a dramatic improvement from where we are. At the same time, we are very aware that there is more to do, and nobody, VA, the medical centers, veterans, all of you, or Oracle is satisfied yet. Last week, I was in Columbus, Ohio with Dr. Evans getting on-the-ground feedback. We met with the medical center's director and leadership team. The bottom line from their feedback is while the system functions, it can be made better. I wish to thank the leadership team in Columbus for their candid, constructive, and well-formed feedback. Providers have felt the performance improvements, but they also want the new system to be easier to use with defaults that are more relevant to their daily work. We can achieve quite a bit of this by reconfiguring the system without touching the code, and it can be done relatively quickly. I'm talking weeks, not months, noting, of course, that direction and permission to do so resides with our partners at VA/VHA. This post-rollout feedback is not uncommon. In fact, we have experienced this before in our commercial business and have always quickly tailored the system to make it easier for providers to use. Nobody in Columbus told me that they want to go backwards. The system is functioning at 5 VA sites and across 75% of DoD and all of the Coast Guard. The Cerner EHR is the most utilized system of its kind on the planet. It supports national and defense health systems in allied countries as well. The core system was built for major missions, and Oracle has invested in making it more secure, scalable, and reliable. It's logical to ask, though, why the VA rollout has been subject to more issues than all of us wish to see. Well, modernization, especially at this scale, is never easy. The initial DoD rollout was similarly challenged in the first 2 years, only completing 4 deployments and then taking a 2-year pause to improve governance and fine-tune a standard enterprise baseline system. Those efforts enabled DoD in a little over 3 years' time to accelerate deployments from 4 sites to being 75% complete today, with 140,000 total users live on the system. The domestic deployments at DoD will be completed this year, on time and on budget. As I look back on what has been accomplished in the last 9 months, I am more optimistic than ever that we are now on the right trajectory and we can get this program on track, on schedule, and on budget. Our working relationships across VA leadership is very strong. Dr. Evans and I have only known each other for a short amount of time, but I think it is fair to say that we are already working from the same page. The VA's recently issued sprint report outlines a path towards better governance and expedited decision-making that will enable, for example, faster decisions from national councils on plans to simplify workflows. Oracle's significantly expanded team is steadily working every day to continuously improve the system and address issues like we heard about in Columbus and that we know that also exist in Washington State and Oregon. We believe, though, from a performance and scalability standpoint, the system is ready for the resumption of deployments. We will work with VA in the lead up to June to evaluate other critical factors that will impact readiness for the resumption of go-lives. These are big things to deliver, and doing so will enable deployments across VA more rapidly with a more intuitive, easy-to-use system. That system will deliver on the promise of seamless care to improve health care for our nation's veterans and service members. We look forward to continuing to work with you and the VA to achieve this goal. Thank you.
Thank you, Mike. And last, but certainly not least, the Director for Information Technology and Cybersecurity at the Government Accounting Office, Carol Harris. Carol?
Thank you. Chairman Tester, Ranking Member Moran, members of the committee, thank you for inviting us to testify today on the status of VA's EHRM program. As requested, I'll briefly summarize the findings from our recently completed review of this mission-critical system. As you know, VA provides healthcare services to roughly 9 million veterans and their families and relies on a legacy system called VISTA to do so. In June 2017, the department initiated the EHRM program to replace VISTA and has obligated at least $9.4 billion on this program to date. It should also be noted that this is VA's 4th attempt at replacing the legacy system, and the implementation so far has been fraught with major issues. In our most recent work, we detail VA's gaps to effectively manage organizational change, as well as the extreme dissatisfaction among users and system issues. This afternoon, I'll highlight 3 key points from our work. First, more work needs to be done to adequately address VA's organizational change management challenges. Our recent review detailed 8 leading practices for change management. VA had partially implemented 7 and did not implement 1. For example, the EHRM program has taken great care to analyze and collect VA's readiness to implement a new workflow and system. But their data indicated that users were not ready for such a change, and the program did not have assurance that it had resolved potential problems in a timely fashion. For example, the Walla Walla and Columbus Medical Centers showed low scores for the knowledge of how to change and the ability to implement change on a day-to-day basis. Program officials said they were taking actions to provide user support in response to those concerns. However, the program did not conduct another assessment before deploying the system. Had they done so, they would have seen that users were still not ready, which was ultimately reflected in the post-deployment survey data. We made 7 recommendations to VA regarding their change management activities, and until they are fully implemented, future deployments will likely be at risk of similar challenges. This could hinder users' ability to effectively use the system, impede their knowledge of new workflows, and limit the utility of system improvements. My second point, users of the new EHR system are generally dissatisfied, and this needs to be addressed before deployments resume. VA is well aware that its users are unhappy with the system. Their 2021 and 2022 user satisfaction surveys showed this. For example, about 6% of users agreed that the system enabled quality care, and roughly 4% of users agreed that the system made them as efficient as possible. These scores are among the lowest we have ever seen on a major federal IT acquisition. Furthermore, VA has not established goals to assess user satisfaction. Having such goals in place would provide the department with a basis for determining when satisfaction has improved, and also help ensure that the system is not prematurely deployed to additional sites, which could risk patient safety. Accordingly, we recommended that VA set these goals and also demonstrate improvement towards meeting them prior to future system deployments. And finally, my third point, VA did not adequately identify and address EHR system issues. VA has not conducted an independent operational assessment of the new system, and as of January, did not plan to do so. This critical evaluation performed by a third party would enable VA to systematically catalog, report on, and track resolution of assessment findings with greater rigor, transparency, and accountability. DoD, in contrast, conducted one shortly after deploying MHS Genesis to its first site, and based on those findings, paused deployment to other sites until the major issues were resolved. Accordingly, we recommended that VA make plans to have the independent assessment done. In summary, the successful implementation of the new system across VA will require a level of program management, adaptability to change, and sustained system performance that the department and contractor have yet to demonstrate. The continuance of EHRM is not without risks, but with strong oversight from this committee, in addition to improved VA program management and contractor system performance, particularly through the implementation of our recommendations, we can increase the odds for success. Mr. Chairman, that concludes my statement, and I look forward to your questions.
Well, thank you very much, Ms. Harris. I appreciate your testimony. I'm going to start with Dr. Elnahal. Dr. Elnahal, I'm sure you're familiar with the Sprint report, correct?
Yes, Senator.
Yeah, last time I checked, there were 14 items on that report that need to be fixed.
Yes.
What is your perspective as far as moving forward with this plan? Do you think that those 14 items have to be fixed before you move on, or do you think you can move on without fixing those?
Well, Chairman, I think it's important to understand that each of these issues needs to, at the very least, be mitigated at the sites where the system already exists, and certainly addressed in anticipation of future deployments. Ideally, the configuration of the system would ultimately change. We would hold Oracle Cerner accountable for making those changes to eliminate the risk entirely. That is the gold standard we're shooting for.
Okay.
But now that we are mindful and aware of each of those risks, which was part of the reason for the sprint, we are at least able to address them at the point of care.
Okay, Dr. Evans, do you feel the same way, that those 14 items need to be fixed before you move on?
I agree with Dr. Elnahal that the items, I mean, we certainly need to have a plan for those items, and we also need to have mitigations in place, which we do, as the record is being used at 5 sites right now.
So the question is how quickly can VA and Oracle get these changes done?
We are in the process of analyzing that. I know that one of them we have already resolved. 5 were actually partially addressed by the Block 8 software upgrade that was just mentioned, and analysis is ongoing with regard to how we might expediently resolve the others. I don't have a timeline.
So I'm gathering by the answer to that question that these are fairly complicated issues, these 14?
Some of them will likely require work by Oracle Cerner to resolve. Some of them may be resolvable through a change in the configuration of the record, as Mr. Cecilia
So
mentioned.
you've been on the job for 3 weeks, and so this is kind of an unfair question. What the hell? I'm asking him, so I'll do it. What kind of time frame are you anticipating it to be? Are we talking years, months?
Not years. I would imagine months.
And is your opinion that before this is moved to, say, a place like, not saying this will be the place, but it could be Saginaw, Michigan, that these have to be pretty well tricked out and done?
I think before we go live at any site, whether it's in Saginaw or any other
Yep.
location, we need to be confident that we are ready to go live
Yep.
and that we have things right.
But you're going to have to look at certain metrics to make that determination. Are these the metrics you're looking at, or are there other metrics beyond these that you're going to be looking at before you move forward?
Those are metrics with regard to the actual solution itself, the software solution and the IT. There are other aspects of determining whether a site is ready to go live, and actually Ms. Harris mentioned some of those. They have to do with whether our employees are ready for the change. And so there's an assessment of the readiness of the people on site where the change is going to occur, and also of the solution itself. The
Is there going to have to be an assessment done of where the EHR is currently being used with those employees
Is an assessment going to have to be done?
there? I mean, you said, we'll use Saginaw as an example. I know Saginaw has been, but you say you have to prepare those folks. Don't you also have to look at the folks that are using it right now and make sure that they're okay with it?
Yes, absolutely. And that's one of the reasons why one of the first things I did was go to Columbus to speak to end users.
Perfect. Mr. Cecilia, there's an independent research firm, Class, I'm sure you're familiar with it. They did a survey of VA users of this system. And the way they put it this way is that Class has measured EHR experience in 280 organizations around the world. VHA Cerner currently has the lowest EHR experience score of any organization measured. That's not exactly a booming compliment. What's your response to that?
Yes, Mr. Chairman, thank you for the question. No, it's not a booming endorsement by any means, and the real shame of it is when you compare it to the line right above it, which is MHS Genesis, which is the DoD system. It's the same system, it's the same code, it's the same database, it's the same data, it's the same infrastructure.
So what
scores are materially higher? When you compare it to Cerner and the general public, the scores, I'm sorry, the DoD's satisfaction is materially higher. The general public scores for Cerner are materially higher and actually among the top.
So
the issue,
the DoD is higher.
Yep.
The VA is not very good. What's the difference?
It's the way well, as I said in the beginning, when you have 345 minutes a month of downtime, you're not going to score very well, right? By and large, we've addressed the issues where the system was not available when it should be available. We've addressed issues like the unknown queue. The remaining issues I would put into the category of things that I heard in Columbus last week, which are usability issues. They are configuration issues, ease of use issues, and frankly, allowing the providers a little bit more autonomy in the system to do some things. These are defaults that populate a drop-down and things like that. This is not a fundamental change to the system. If it was a fundamental change to the system, then it would be illogical for me to think that the system could be working, the same system could be working not only in other customers, but in other sides of government as well.
I'm going to turn it over to Senator Moran here right now, but the bottom line is that at some point in time, how much money are we going to have to spend to make sure this program works and that veterans get the health care that they've earned? That's it. I think that there's plenty of blame to go around, and I'm tired of putting blame out. I want to see production, and I want to see results, and I want to see time frames for both. Senator Moran?
Well, Follow up on a couple of things that you outlined in your questions, Mr. Chairman. First of all, a continuation of this discussion, because, Mr. Cecilia, what I think I hear is that given a little bit more time, the system will fundamentally work. The fixes that need to be made are made, but there's still then, as Dr. Evans indicated, the operational aspect, what needs to happen within the healthcare system to be able to utilize a system that technically is capable. So, I mean, is that a fair assessment of what you were saying, is that there's two components here?
Yeah, I think that is a fair assessment. I mean, obviously, there are things that I would describe now as we get past the major, catastrophic interruptions to the system and into more ease-of-use systems. Again, these are fundamentally easier things to change. These are not hard engineering efforts to change these things. These, as I said, these things can be changed in a matter of weeks, not even months, but weeks. Then, obviously, there's change management, there's training readiness, there's site readiness, there's connectivity readiness, and all of those things that have to be continued to be assessed on a site-by-site basis as well. So I would think it's fair to say that both of those things need to happen.
Dr. Evans, welcome to this capacity that you now serve in. Would you respond to that? I mean, if the system was working, that the technical capabilities of the system were there, then how much of the problem is solved? So let me ask it this way. So Cerner has an obligation to get the system to work. The VA has an obligation to make sure that's the case, but in addition to that, to train, educate, utilize, figure out how to utilize the system within the VA. So if the system had technical capabilities to function properly, then how much of the problem has gone away?
So first of all, I don't think we are yet at the point where we can say with full confidence the system is technically performing where it needs to be.
I didn't say that, and I don't know that even Mr. Cecilia said that. He says they're in the process of fixing these problems. My question is a hypothetical. If they fix the problems within the system, the technical capabilities of the system, then are there still problems left with the VA and its implementation? The system works. Can the VA then utilize the system and care for veterans?
Yeah, so I think in many ways the question you're asking is, are end users in the VA ready to adopt this change? That is, if they're given a system that is highly reliable, where there's not a lot of lag in the system and they're not watching the spinny wheel, where it's doing what they need to do to be able to enter orders, order prescriptions, review the data that they need, that the tool is kind of getting out of the way of clinical care, are they ready to adopt and move to this new solution? I think the answer to that is yes. I think VA clinicians, clinical staff, they want a tool that's going to help them take care of veterans. That is their motivation. There's work we need to do to make sure we're preparing them for that change, that we're helping them understand what that change is, that we're creating a feedback loop where we're understanding what the issues are and then rapidly resolving them. But I do think they are ready to move in this direction.
Dr. Eldenhall or Dr. Evans, either one of you may answer this if you would. The GAO recommended you establish user satisfaction targets and measure progress toward meeting them prior to future system deployments. Do you commit to do that and stop the future EHRM deployments until user satisfaction is met?
I'm happy to start, Senator. I think it's an important question because there really isn't much daylight between users believing that the tool in front of them, our clinicians, is the right one to be able to serve the clinical needs of veterans and the actual veteran outcome, which is what we're all shooting for. And so absolutely, it is important for us to increase user satisfaction. We do so through multiple ways. We have to, again, change the configuration of the system, as Dr. Evans mentioned. We have to train right. And we have to assess that as its own target moving forward. So yes, we do commit to assessing user readiness and user adoption and satisfaction.
But if you assess, I appreciate that you're going to assess, but then the question is, what are you going to do with the assessment until that assessment indicates that the user satisfaction is where it needs to be? Then are you still going, if it's not there, are you still deploying to new sites within the VA?
Well, if you ask me in a vacuum, Senator, I would want user satisfaction to improve substantially. That is an outcome that I'd want to see, but especially before we accelerate deployments in a manner that DoD has been able to accomplish. I think that users will.
Sorry, what's the vacuum that you're in? You have a set of criteria. The GAO says meet the criteria. The question is, do you pause before you send more, before you deploy more to more locations until that's met? I don't know the vacuum that is. Just criteria not met, you're still going to deploy?
Forgive my wording. What I meant to say was we really want to see user satisfaction improve, and I believe that it will improve once we do follow through on all of the Sprint solutions, which is a combination of holding Oracle Cerner accountable for configuration changes, for us to improve training, and for us to organize ourselves and support our end users with the right change management, which had everything to do with our build of governance. So yes, I would want to see end user satisfaction improve before we accelerate deployments. I don't know if Dr. Evans, you have further.
I agree. I mean, I think there's still an opportunity, there will be opportunities to learn, but to your point, we have folks who are using this system on a daily basis where we can assess an improvement in satisfaction. And, you know, I do think that there is, we just released 3 critical pharmacy updates, and we're hearing some good news about those pharmacy updates. There are more to come amongst the pharmacy community. So there are places where we are starting to see some user satisfaction improvement, but to your point, we need more in order to support any acceleration of a schedule.
I'll come back to this in a second round, but I think my question is worthy of a yes or no answer, and I don't know what the answer is, so I'll come back to it.
Senator Murray.
More time.
Mr. Chairman, thank you very much. You know, we are almost 5 years into this EHR contract, and from the very start, before the original Cerner contract was even agreed to by the Trump administration, I have been raising concerns from my constituents in Spokane and in Walla Walla, and I believe that I have been very patient and reasonable in pressing the VA and Oracle Cerner to get this system to work the way it should. Now, I have heard from providers who are now burned out trying to navigate this broken interface on top of what has already been an incredibly trying time for healthcare workers. And I have heard directly from my constituents who have received a late cancer diagnosis because of the flaws in the system and everything in between. None of this is okay. And something that concerns me deeply is we have not heard a lot about how those voices, that on-the-ground perspective, will be taken into account when we determine the future of this program. VA is now in the decision-making process about whether to renew this contract. This is a key moment. So, Dr. Elnahal, I need to know who is representing the front-line experience from Eastern Washington who's been using this system, and how exactly is the patient and provider experience represented in that decision-making?
I think it's a really important question, Senator, and we focus squarely on that in the Sprint effort in collaboration with the program. We built a governance structure that takes the views of end users into consideration in the first instance. The most important input we have is the input we have from frontline clinicians like Dr. Evans, who are telling us about the problems that need to be fixed to meet the veteran care need. That cascades up into different levels of governance, our clinical councils, that ultimately make decisions on the changes we need to be able to meet
so
safe
it isn't
and
the
effective
users who've been facing these challenges over and over again?
Yes, our governance now includes users from the 5 sites where it exists and leaders who are advising on what changes need to be made based on their input.
Okay, well, I'd like to see that chart.
Absolutely, Senator.
Mr. Cecilia, Man Grandstaff has been dealing with serious and even life-threatening issues for over 2 years now, since the rollout of the EHR. And many of the OIG reports have further confirmed what I have been hearing on the ground over and over. There are problems in the system with suicide flags, with unknown queues, pharmacy issues, and I know that Oracle has begun working on some of those fixes, but we are still talking about the same problems 2 years later, and that is just so unacceptable. The stakes are really, they couldn't be any higher. So just tell me, why is it taking so long to update this system when we've been telling you the problems and, you know, from the ground up 2 years ago, and we're still getting the, well, we're going to have a fix for this?
Well, thank you for the question, Senator. To my knowledge, the unknown queue issue has been addressed. I committed to this panel in July that we would deliver a fix on August 1st of 2022. We did that. It is deployed, and now, on average, there is 1 order per day that shows up per site in the unknown queue. I think the last time we spoke here, we were up about 1,500 orders in the unknown queue. So if that is still a problem, that is in fact news to me, and I'm happy to come back to you in writing if there are additional problems, but I've not heard those. In terms of pharmacy, the last time we spoke, the estimate was that it would take 3 years to address the pharmacy's issues. My response to that was, when that kind of estimate is given, the real answer is nobody knows. So the first thing we did after that hearing in July was broke that down into smaller subsets. We delivered in February the top 3 fixes for pharmacy. The 4th fix, number 4 on the priority list, will be delivered in April to the VA. As Dr. Evans just mentioned, we have heard some positive feedback from sites about those pharmacy fixes. As far as behavioral health flags are now in the system and will continue to be added to all modules of the system on schedule in April. As well, the opioid advisor tool that has been deployed has flagged over 1,600, just at the 5 sites that are live, has flagged over 1,600 potential opioid prescriptions that would have been made to patients who perhaps should not have received opioids. So I think a lot of the issues that have been reported have been addressed. I'm disappointed to hear that that news has not made it to you, and certainly we will make sure that we respond in writing with affirmative data on each one of your questions.
I would like to see that in writing. Mr. Chairman, but before I finish my time, I just want to say, as Chair of the Appropriations Committee and Chair of the Military Construction and Veterans Affairs Subcommittee, and a longtime member of this committee, I take my oversight responsibility pretty darn serious. And despite how much funding has been provided, this system is by no means living up to our promise to care for our veterans. The continued patient safety risks are totally unacceptable. So I want to be candid here, because at the end of the day, what I care about is getting this right for our veterans. And I do not believe that more money is what is going to solve this problem. And I'm not sure it makes sense, Mr. Chairman, to continue to fully fund the budget request for this system until I can see that the system is working and not putting our veterans in harm's way. That responsibility is on both the VA and Oracle Cerner, and both entities need to step up.
Senator Murray, thank you for those comments, and I would tell you, in short, our patience is running thin. Coach Tuberville.
Thank you, Mr. Chairman. Thank you, and thanks to the witnesses for being here today, for discussing such an important topic, one that I know has taken many years and a lot of money. We need to do what makes financial and logistical sense, and most importantly, make sure it works for veterans and VA's healthcare providers. I hope we are well on the way achieving this goal. However, I'm going to use my 5 minutes today to relate to another topic. It relates to an interim final rule issued by the VA last September that allows the VA to provide abortions to veterans and their dependents. Since this rule was implemented 6 months ago, the VA should be able to provide this committee with the data. Dr. Ellenall, I have several questions I want to ask you, and see if you can answer some of these. And I'm going to ask all 3 of them first and see if you can answer them. In the last 6 months, how many abortions has the VA facilitated, either at a medical facility or through community care? Number 2, at what stage of pregnancy was each of the abortions? And number 3, what exception was used for each of the abortions? Can you answer any of those 3?
So, Senator, respectfully, in a public forum like this, I'm concerned about both veteran and clinician safety if I give you that information right now, but we're happy to work with you and take that for the record.
Thank you. I figured that was coming. Well, next questions, we shouldn't have privacy issues, so see if you can give me a response on these. Which VA doctors, therapists, social workers have been trained to counsel and refer veterans for abortions? How have they been trained, and how has the VA assessed their competency in women's health and prenatal care? Do you know that?
Well, Senator, we want to ensure that the folks providing these services, again, in the limited exceptions that we have as defined by the IFR, the life of the veteran, if the health of the veteran is at risk, or in situations of rape or incest. And we need trained, qualified professionals to do that. So we've rolled out training. We've begun to do that, of course, for our women's health providers, our coordinators of care for women's health, our mental health providers, where these conversations can come up, and that process is ongoing.
But haven't we changed it to where abortion at any time, not the 3 exceptions?
The criteria, Senator, is if, again, the veteran's life or health is at risk, or in situations of rape or incest.
Those 3 exceptions. Okay. All right. It's my understanding that doctors now have the option to opt out of participating in this policy. Is that true?
That is true, Senator.
Okay. How many doctors have chosen to opt out? Do you have any clue?
I don't have that information now, but we'll take that for the record and see what we can provide.
Was that included in this new rule, that they could opt out?
Under the law, physicians have always had the right to opt out of care that they against which they have a conscientious objection, and we made that clear through formal policy and the exact process by which they can do that. Very recently, we sent that guidance out to the field.
Yeah. Do you know, do you have any clue how much it's costing the Veterans Administration to implement this rule? Do we have any kind of report on that?
Well, the impact analysis, Senator, that we've done estimated that fewer than 1,000 veterans a year would need these services. And so we're really not talking about a significant percentage of the medical appropriations budget that we have.
Yeah. We've had this new interim law for 6 months, and I hate that we can't discuss it a little bit more. I'm curious, what prohibits us, from privacy. I understand a little bit of it, and I'm, really just wanting numbers. Last time I talked to Secretary Madonna about this, we had started abortions, and so hopefully that we can get some numbers down the road. I think there should be an obligation from the VA to do that since it was changed from the VA and not through this body. So hopefully we can discuss this and get more information in the future. Thank you. Thank you, Mr. Chairman.
Senator Brown.
Thank you, Mr. Chairman, very much. I thank you to the Chairman and to Senator Bozeman for the discussion this morning over the Air Force breakfast and talking about patient safety and talking about mental health and all the things, treating men and women in the service and after they get out of the service as human beings. This week is National Patient Safety Week. I hear directly from VA employees in Ohio regarding safety concerns at the VA. No surprise. We should applaud those who have the courage to make sure veterans are receiving care in the safest possible environment, speaking out about it when necessary. I want to take a moment to thank Dr. Cox, who testified last year in the HRM, for his team at VHA for their work to make the electronic health record safer. We know VA's electronic record rollout had led to negative outcomes for Ohioans. As Mr. Scalia talked, you were in Columbus recently. Today, my office was briefed on 3 separate veterans, 3 individual veterans who died in part because of the Oracle Cerner EHRM's failings. Until the 14 technology fixes outlined in the HRM Sprint report are developed, tested in place, this should not move forward at any other facility. I think you're hearing that from the chairman, the ranking member, Ms. Murray, and others. My first question is for Dr. Evans and Dr. Elnahal, if you would respond to this. I met with VA employees in Columbus a few months ago, right after you announced the assess and address period to find and fix problems with the HRM product, and after Dr. Elnahal's September visit. Frontline VA employees raised frustrations, the kind of frustrations Ms. Murray spoke about connectivity, system latency, workflows. Clinicians raised pharmacy and patient safety concerns, where they went around the table one after another talking about those. We see the effects on productivity, on worker morale, on veteran satisfaction. In January, specific clinics' productivity were still below go live and access to specific clinics at Chalmers, the Columbus facility. Primary care, rheumatology, neurology remain limited. Since go live, the facilities hired additional staff, and employees are working overtime to meet veterans' needs. You know all that. No new system launches perfectly, of course. However, we're almost a year post go live in Columbus. Veteran satisfaction is low, worker morale is low, as indicated by the GA report. So how, Dr. Elnhaw and Dr. Evans, how can you recommend moving forward to more complex facilities if the current sites aren't back to go live productivity levels? I mean, you've talked about Cleveland, you've talked about Cincinnati, you've talked about Ann Arbor, you've talked about Seattle. How do you go to more complex facilities when you can't get it right in an ambulatory place like Columbus? In either order. Dr. Evans, you want to start?
Sure. First of all, I was just in Columbus myself last week, and I heard many of those same things. And we need to address those issues. There's just no two ways about it, right? This is, in any system, as you said, there are going to be challenges when we roll out a new system, but it is very, very important for us to be sensitive to the operations on the front lines of care and to be identifying where those challenges are and fixing them. To your question about highly complex sites, like those that you mentioned that have some of what we would refer to as our level 1 medical centers, where there's more complex care delivered. I think, the VA recently made a decision to move back. We had been considering moving forward with a go live in Ann Arbor, Michigan. And
This fall, right? This late summer or fall?
That's
as early
correct.
as that.
That's correct.
And you've moved that back?
We have moved back.
As you have Cleveland and Cincinnati?
That's correct.
Okay.
And I think, again, this gets to the core principle that I mentioned earlier, and that is we need to know that we are ready to safely deploy a record that will meet the needs of the organization before we go live at sites, particularly at complex sites, but I would argue that would apply to any site. It doesn't matter whether it's highly complex or not complex.
Okay, Dr. Elnhaw.
Yeah, thanks, Senator, for the question. As you remember, it was actually my visit to Columbus where I heard directly from frontline users and I observed their workflows about the concerns they had around veteran care that prompted us to do the assess and address after I had a conversation with the Secretary about what I saw. And the need to restore productivity isn't an end in and of itself. It has everything to do with access to care. And it's also a marker about the degree of workarounds and issues that our clinicians have to go through to work around the system rather than having the system function for their needs. And so I do see, and I agree with everything Dr. Evans said about a site-by-site assessment that considers not only productivity, but everything else we've discussed, patient safety risks, a number of other metrics. But there is a ray of hope in that Walla Walla has just reached pre-deployment productivity recently. They have strategies for their workflows that have been able to achieve that. And so we are learning deeply from that experience. And we plan on having that experience be taught and shared in terms of those best practices, not only for sites going forward like Saginaw, but to sites that already have the system like Columbus.
Well, thank you. And, Mr. Chairman, thank you for giving one. Mr. Sealy, I'd like to ask you one question. It's been a year ago, and since the purchase of Cerner, since that time, VA employees have told me a lot of things. IT tickets being closed without communicating that back to clinicians, degradations, outages that affect veterans' clinical care, not properly testing upgrades before they go live, which cause pharmacy shortages. You're aware of this. I just don't see the benefit from your system. Veterans frustrated by delays in their care. The contract's coming up for renewal in May of this year without significant changes to the terms of any contract. Why should we support it? What benefits can I start seeing that you're providing?
Well, I think in the issue of tickets being closed, this was feedback that I heard in Columbus last week, and I would agree with you. It's not where it needs to be, and that's on us to address that. And the issue of system availability, though, I think we've made dramatic strides, and we are now at the 99.9% system uptime SLA that is contracted for. So I believe that some of that data is from older reports, and things have been remedied certainly in recent months. It's been 9 months since we've owned the system and made material changes. As I said, if the core and fundamental aspects of the system were flawed, it wouldn't be powering healthcare for countries like the United Kingdom and others. So there are issues. We're working together with the VA and the VHA, and I think that list of 14 accurately summarizes the things that need to be addressed. 7 of those are already addressed and not yet rolled out. The other 7 are in planning to be rolled out. So I do believe that we with the new leadership and the folks that have leaned in at VA, we have very good understanding of what needs to be fixed clinically to make the system better. I do know that the system does work and can work because it works all over the world. Obviously, this implementation has been particularly problematic. But as far as not testing the system and causing outages, my firm belief is that those days are behind us. I don't see that as a continued issue going forward. It hasn't been.
Senator Tillis.
Thank you.
Thank you, Chair Tester. Thank you all for being here. And Chair Tester, I'm glad that we have a panel instead of 2 panels. We've got all the stakeholders at the same one. Ms. Harris, I spent a lot of time doing large-scale systems implementation work, contracts, fixed price, all that sort of stuff. As your office completed the review, how did you make any determination? I have not read the report, just a summary. Any determination about contract obligations and where and who was responsible between Cerner and the VA and the execution?
That was not part of the scope of the review that we performed, but I mean, I think that it's fair to say that Oracle Cerner has not performed as well as they could have, given the volume and the severity of the system issues that have occurred, and also the lack of timeliness to resolve them, which was part of our review in terms of the trouble ticket resolution and not meeting the SLA timeframes. Clearly, I think that the contract as currently written has not sufficiently motivated Oracle Cerner to perform better. I mean, just in looking at the ticket resolution timeliness, just on that alone. I think that the other component of that is the IT oversight piece on the side of VA. I think that this is a relatively new thing for VA. They have for 40 years been in the business of building systems like Vista, and it's a completely different skill set in building IT versus buying, as you know. And so I think the department has struggled to make this transition, and that's evidenced by its past failed attempts to replace Vista with other commercial products, as well as what you're seeing going on right now.
Okay. And Mr. Cecilia, you mentioned that I think you said that you transferred ownership of the system about 9 months ago. Can you give me, if you have the information in front of you, the trouble ticket resolution, is that an ongoing, you've transferred ownership, I'm assuming they're going through an implementation, they may need some fixes to address process issues. Where are we now in terms, I would have expected a lot of trouble tickets before you went live in the Northwest, fewer now. Has that happened, or do you have a continuous flow of additional requests?
It's not uncommon to have a continuous flow of tickets in a system this big.
More of a scale issue.
Yeah, I think the current issue and the feedback that I heard on the ground in Columbus was that there's a feeling among the providers, the end users of the system, that we are closing tickets too quickly in order to meet a metric. And I think, frankly, that feedback was probably fair. I think there are some things that we need to do better, and we took that as an action item to get through. But we have closed. We did in part of the sprint. We closed 94% of the outstanding tickets. I'm not so sure though that the qualitative measures are the only measures that matter. The quantitative measures, the quality of the close, communication back to the end users is an area for improvement. I don't think we're at the point, and I do not have the numbers in front of me here. I'm happy to supply those back in writing. I don't think we're at the point where we have a massive amount of tickets that we don't know what to do with or have issues that have not been surfaced in the past.
Mr. Nohal, did I pronounce your name right?
Yes, Senator.
Okay. I know that you all are moving forward with the current implementation date. There are some improvements that have been recommended, and does that suggest that the improvements will be implemented, or you're moving ahead and you'll work on any sort of recommendations from the GAO as you can get to them?
So read through the entire GAO information that was received from Ms. Harris and digesting all of that. I do want to reinforce that we are going to assess readiness site by site. And so when you say that we have a notional schedule, we have a schedule, but the assessment for readiness for deployment of Saginaw has not been completed.
All right, so you'll do a go, no-go based on that assessment.
Exactly, and we are reviewing all the improvements we think need to be made before we would consider the likelihood of a safe and effective deployment to occur.
I'm about out of time, but I anticipated that you're going to have some challenges, because if you take a look at the VISNs and you take a look at the way that they have matured over years, they're like fingerprints. When you started this process, you had several different variations, in some cases variations within a given VISN that you had to deal with. That is a huge systems process change management challenge. So it's not surprising to me. The scale of it in terms of cost is a bit surprising. But I think it's important for everyone to know that we have to plow through, we have to address these problems. One of the reasons why I was okay with the Cerner decision is it's a common platform with the DoD. I know they're not perfect, but my ultimate goal is to see integration there. My last question, as you go through implementation, has to do with what I heard just earlier about one of the things that we wanted to make sure got done, which seems to be having some problems right now, is with non-VA care. And when you look at the implementation of the PACT Act and the additional stressors that I think are going to drive you to non-VA care in many instances as you ramp up, has that problem been solved? Are we going to see that integration, that ability for non-VA providers to access the same chart in a reasonable period of time? And that's for anybody that can answer the question.
Yes, Senator. I think actually this is a particularly important part of what we've accomplished in this project already. As a part of related to, but not directly related to, the electronic health record change itself has been the implementation of what we call the Joint Health Information Exchange. And we, the DoD and VA combined, as well as the Coast Guard, the federal electronic health record, are now exchanging data through the Joint Health Information Exchange with 65%, I believe, is the last I saw, of the American healthcare system, records digitally. And those are available not just to users at the 5 sites that are using the Oracle Cerner EHR, but can be reviewed as well by clinicians at sites that are still using Vista.
I may be working on dated information. It was, I got the impression, and I'll go back to the person that informed me on this, that exchanges are something I spent some time on in the state legislature. It's one thing for one of the providers to publish it. It's another thing for people to fully subscribe to it and exploit it. So I'd be very curious if that 65% number, and I'll take it at face value, it'd be interesting to see if they're fully exploiting it in the manner that I would expect them to, and it would be the same way that any healthcare provider in the VA would. Thank you, Mr. Chair. I'm sorry I went so far over.
Senator Blumenthal.
Mr. Chairman, thank you very much. I've been on this committee for a little more than 12 years. I've been on the Armed Services Committee the same amount of time. I don't know whether you have recently read the Iliad and the Odyssey, about the decades-long war that the Greeks conducted. This reminds me of the Iliad and the Odyssey. It seems endless. And I don't know what to tell my constituents about why it seems to have been such a dismal failure. Can you tell me, Dr. Evans?
I have teenagers who are taking high school English, so I have seen the Iliad and the Odyssey recently at my house. I think as for the question of the change here, this is a very, very, very significant change for the Veterans Health Administration. As I mentioned in my opening remarks, electronic health records really, it's much more than a record. It's what drives the workflow. It's what, frankly, in many ways supports how clinicians think about patient care. And so I think it's important to understand the depth of the change.
I know it's an important and complex change, but it's equally important and complex for a lot of very big corporations that get it right, and then they have to change, they have to update. This technology is changing. I almost feel like the VA begins to get there, and then somehow the system escapes them because of advancing technology, because they don't, I say they, because it isn't just you, it's a decade plus. Would you say that the VA is now fully integrated with the Department of Defense?
So I've been seeing patients at the VA for 21 years. I can't remember a time in the last decade where I was not able to access data from the Department of Defense healthcare system in order to support a patient who came into my clinic who had either received care in the DoD recently or was receiving care in both
But with all due respect, sir, that doesn't answer my question, because the fact that you could access records doesn't mean that the systems are integrated electronically. If you're saying, yes, it's done,
Right.
I
Well, I
accept
think,
that
so
answer.
here's what I would say. So interoperability has multiple layers. If we're talking about, is the data available digitally for me to review in order to understand and take care of patients? The answer to that question is yes across the enterprise. But is that enough? And the answer to that is no. We need to get to a point where the data is not just available, but it is computable, so that the colonoscopy that was done 8 years ago triggers a reminder for me to order a new colonoscopy at the 10-year mark for a patient. That is, that I don't have to go look it up in a digital repository somewhere, but that data element is driving clinical care decisions. And that's what we're striving to achieve with this.
But and the answer then to my question is no, it's not fully integrated, because if that patient had gotten that kind of test 10 years ago only within the VA system, I presume that after 10 years, or whatever the right time is, there would be a red light that goes on and you would have said, Joe, you need to come back. If it's not happening from the DoD to the VA, you're not fully integrated. And I'm running out of time. So I know this is a big and complex question, and I know I've asked it very simplistic way, but
And if I may, completely agree, and that's where we are headed with this project. That is the benefit of having an integrated federal record, and frankly, the benefit of having health information exchanges with the Oracle Cerner record, that records we're getting from the private sector can be ingested into the VA record to drive that kind of clinical decision support. So that is where we need to go.
My staff was told yesterday that there were 6 catastrophic events related to a feature of the Electronic Health Record Modernization Program in the last couple of years. 4 of the events resulted in a fatality, 1 from Spokane and 3 from Columbus, Ohio. Is that accurate?
Let me just start by saying that patient safety is incredibly important to us, and I think you heard Dr. Elnahal mention that. One of our goals in VA is to see 0 patient harm. Hard to achieve. Healthcare is an inherently risky endeavor, but our goal is zero patient harm. And we take every episode where there is harm, and we evaluate it very carefully. And we try to understand why. And often there are many contributors to what can lead to unintentional patient harm. It's never good. We are never satisfied when this happens. But we learn from it by identifying what the factors are. And there are many factors, medication errors that can occur, the electronic health record can contribute, physical infrastructure issues in our facilities. There are many potential contributors to patient safety, of which the EHR is one. And yes, there have been cases where we have found that, frankly, with both our EHR on the Vista side, as well as with the Oracle Cerner EHR, the EHR has been a potential contributor to that harm.
A potential proximate cause, as we say in the law.
Senator Blackburn.
Thank you, Mr. Chairman, and thank you for the hearing. This is something that we have followed for months, as you all know, and it is a source of frustration for us that the implementation is not happening. Mr. Cecilia, I'd love to come to you, and I appreciate the efforts that your company has made in developing a new platform that would modernize the EHR structure. We hear that that's been a problem. We think it could be helpful. This rollout has not met the expectations of anyone. Transitioning these platforms are difficult. At Vanderbilt Hospital there in Nashville, there was a lot of pioneering work early on that went into the EHRs and how they could be utilized. There has been frustration that the VA has just not been able to make this system applicable, user-friendly, interoperable. The list of questions go on. But what I'd like to hear from you, let's just say if this program is unsuccessful, if you can't get this platform going, what challenges do you see in integrating electronic records among the various shareholders that might need these, DOD, other VA programs, people that are going to go into community care? So kind of walk me through what the challenges are on this.
Well, if the program is not successful and it would revert back to Vista, which is the current system, Vista was created on a technology called MUMPS, which was introduced during the Carter administration, and by and large still remains on the same platform. I think interoperability would be a real challenge because those systems are very difficult to get to modern cloud platforms and to turn into what's usually called software as a service, which means that the system is automatically updated, automatically secured, and automatically maintained by, in this case, the vendor, Oracle. So I think that becomes, to be a very difficult.
Then let me ask you this: have you seen VA's program for restructuring?
Excuse me?
Have you seen the VA's proposal for restructuring? Are you read into that?
For restructuring Vista? Or
for their entire EHR.
Well, we are the vendor for...
Right, but VA has an approach. Are they working with you? Are they stonewalling you?
No, they are not stonewalling.
Okay.
VA is not stonewalling. I would say, particularly with the addition of Dr. Elna Hall and Dr. Evans in the last few months and weeks, I would describe the collaboration among all parties as excellent, certainly better than it's ever been in the 9 months that I've been associated with this program, and I'm very optimistic that we are at exactly the moment where DOD was in their initial rollout, which I would call a page-turn moment. And I think we're...
That's great. That is good to hear. So do you feel like your recommendations are being listened to and that VA is responsive?
I do.
Okay. And Mr. Del Bene, let me come to you, because in your nomination hearing, to my QFRs, I asked you about the EHR modernization and flipping this system, making it workable. And here was your response. What's most important is to make sure that these projects run in a highly effective manner, accomplishing agreed-upon goals for each project in a cost-effective manner. So the posture this program is in right now, is it cost-effective? Is it highly effective? Is it meeting agreed-upon goals? Where are you on this?
Well, thank you for the question. I definitely think we've made progress, as been cited by the uptime hitting the goal recently. I think we still have a ways to go, to be honest. There are another set of measurements, kind of the second click down, where we're not yet meeting the goals. One is uptime or incident-free time, period of time when there's not an incident in the implementation somewhere. We still aren't meeting a goal there. But we're making progress, but there's a ways to go still.
Okay. And Ms. Harris, the GAO finding, VA medical staff appear apprehensive about adopting the new EHR system. What is their dissatisfaction? Why are they apprehensive? Why do they not want to move to an EHR system that could be interoperable, that you could have some of your multi-stakeholders, DOD, utilizing an interoperable system? Why are they resisting this?
I think change is hard, and I think that, you know, within VA in particular, for the past multiple decades, these medical centers have been able to do what they want, which is evidenced by the 130 versions.
Do they understand this is their job? Is it the union that is resisting? Who is resisting on this? Why do they not want to do this? I have never in my life seen such resistance to modernizing a program. You've got a vendor sitting right next to you. They're making a good faith effort to bring something forward. Why can you not tell employees this is your job? If you don't want to do this, go work somewhere else.
We have not done the detailed work to get to what you're
What's your timeline?
Asking.
What is your timeline for getting this program to the point that you're going to be able to see VA? I mean, you're the GAO. You're telling them what they're doing. I guess that question is more properly placed to another of you on the staff, probably Mr. El-Nahai. What's your timeline? How long does the transitions take? I know that the chairman asked you, and you said months.
Well, I think the thread of your question, Senator, has a lot to do with the responsibility we have to take in the healthcare system to prepare for the change and execute on the change. And we took that seriously with the sprint effort that we submitted to all of you on this committee. We've built a structure that holds all of our leaders accountable for owning this effort, but also one that requires us to really define the changes needed so that at the end of the day for our end users, it is usable and it's an efficient system.
I'm way over my time. I hope you all realize the frustration is that VA ought to be able to do this. And there does not seem to be a willingness. And Ms. Harris, I appreciate that GAO had that report for us. But I think we're all frustrated with the lack of willingness to modernize the system and be of service to the veterans. Thank you.
Thank you, Senator Blackburn. I'm going to stick with you, Ms. Harris. Your report, and I think in your opening statement, you said that there was one remaining recommendation that hadn't been addressed, or did I hear you wrong from the report?
Well, we made 10 recommendations in
How
our
many are
most-
still open?
They're all open.
They're all still open, so that means they haven't been addressed, right?
That is correct, but VA did concur with all those recommendations.
And how old are they?
I'm sorry?
How old are how old were these recommendations? When were they made?
Well, we've made a total of 15, well, we have 15 open recommendations related to EHRM. The oldest one is from June of 2020, or I'm sorry, 2021.
Okay. So, you only been on the job for 3 weeks. What's the plan here? I mean,
I think that some of the recommendations that were mentioned are just coming out right now. We concur with them, and we will be acting on them. I mean, change management, communication,
Yeah.
it's critical.
okay, good. Going back to you, Ms. Harris, have you ever seen a contract? Do you look at contracts? Do you look at contracts?
We do look at contracts,
Okay,
yes.
have you ever seen a contract that, who I believe, you correct me if I'm wrong, okay? Because I'm not always right. Have you ever seen a contract that appears to be really out of balance, favoring the vendor, and where the agency oversight of that contract, I believe, is lacking?
Well, I think that the contract certainly is not necessarily in the best favor of the government in this particular case, to be blunt.
Okay, good. So that brings me to you, Mr. Parrish, who haven't been asked any questions today, and I don't want you to feel too lonely down at the end. But where are you at in contract negotiations?
Well, Mr. Chairman, as you may or may not know, we've begun our renegotiation of the contract for the new option period that would theoretically begin on the 17th of May. However, given the procurement rules, I'm limited in what I can actually give the details on in a public hearing. But that said, I do want to...
So let's just ask you it this way. Are you going to do you intend to have a contract negotiated by the time this one runs out, which is what, the 17th of May or something?
Yes, sir. So a couple points that I can add for you is the key component is as you everyone on the committee has acknowledged that there have been some challenges around system reliability and user adoption, and we've insisted for those improvements to be made by Cerner, and they've done some, but nearly not enough. And so one of the key items that we're doing and we're looking at instituting is improving the frustration that you acknowledged around the limited enforcement mechanisms of the May 2018 contract, because it is very restrictive in what we're allowed to. As you acknowledge, we only received $325,000.
So let me ask you this: how is that enforcement applied? Is it applied via the checkbook, or is it applied some other way?
Well, right now, as you know, it's very limited, but what we intend to, what we are renegotiating with the Oracle team is to strengthen and add more enforcement mechanisms, especially around service level agreements. We want to bring industry standards in.
But how do you hold their feet to the fire? Is it going to be by money?
Yes, sir. It'll be by money and by I guess that's really the main.
Do you anticipate this next contract will be more favorable to the American taxpayer? And
that is absolutely the plan. Yes, sir.
Okay. Dr. Cassidy.
Hey, thank you all. Ms. Harris, I think your latest recommendation was that there be an independent review of this process to just kind of have a third party look at it. Sometimes you're so close. It doesn't mean the VA is not doing their job or Oracle. It's just that you're so close you can't. What do you think about that process being a regular process? It wouldn't just be this one time, but it'd be whatever, once a year, once every 6 months, some interval in which some objective person could say, let's everybody step back, I'm a new I, and X, Y, and Z. Thoughts about that?
I think that makes a lot of sense. I mean, the more eyes that you have on the system implementation, particularly an objective third party, the better. And you look at DoD, for example, in their rollout of MHS Genesis and having that independent operational analysis completed after their first initial deployment. They put a pause based on the results of that assessment. They addressed all the major findings there, and then subsequently restarted the deployments, and it was much smoother.
Because it's kind of a tale of two departments. Apparently it's going kind of swimmingly in the DoD with high provider satisfaction, and it's obviously not going very well in VA with very low provider satisfaction. I'd be interested in knowing more about that, but it sounds like you're somewhat attributing that to this sort of third party coming in. Okay, stop everybody, time out, almost like a marriage counselor, and then kind of getting things back online. Is that a fair characterization?
Yes, it's objective and it's comprehensive, and it would allow VA to systematically catalog what the major issues are and then to address them point by point.
Which of the gentlemen from the VA should comment on this? I apologize. I've been at a series of meetings out of here as to whether or not you would accept that or even think it's a good idea.
Again, I'm new in this position, but I will say this. I completely agree that the perspective of those who are outside of the narrow window of executing a program is valuable. And frankly, we value the input from the GAO, we value the input we receive from the OIG, and we value the input that we receive from other partners.
So knowing that you value it, but I'm really asking, would you be open to systematizing this third-party review? That it wouldn't be an ad hoc, maybe it's about time to do it, but rather apparently such as DOD did on a regular basis. Oh, now's the time for the person to come in, kind of like JCAH coming in for a hospital. I don't know if they go to the VA or not, but everybody makes sure that everybody kind of resets. Your thoughts?
Yeah, I mean, I think, look, I would certainly be open to having those discussions to figure out what that could look like.
That's a little bit...
Or do you want me to say, I mean, yes.
Okay. Mr. Cecilia, what do you think about that? Is there value there?
Yeah, I think that it's a common practice among our commercial customers that third parties do quality reviews.
A common practice
among our commercial customers.
Yeah, I heard what you said, but I just was kind of
Yeah.
digesting the thought that the common practice, the best practice, which has worked with DOD and worked in the commercial setting. And I'm not pointing fingers at anybody. We're trying to find solutions here because we're 30 billion in and counting apparently in terms of potential liability. Mr. Cecilia, have you ever met with Secretary McDonough?
I've not.
How about your CEO?
No, she's not.
Is there any value in you meeting with him?
I think we did make an offer for a meeting. It's not yet been accepted. It would be common that we have top-to-top meetings in a deployment such as this size.
I apologize if you've answered this, but again, I've been gone. Is there just a succinct answer why this is going so differently in DOD versus how it's going in VA?
If there was very succinct and very easy, I think we would have flipped that switch. I would say that the range of services in the VA is more complex than it is in many cases in the DoD. However, in upcoming go-lives this month, we will go live at some of the most complex DoD sites that there are, and the readiness assessment on those is squarely in favor of a go-live in the system.
Can I stop you for a second? It does seem, though, that scheduling and pharmacy benefits are core competency of any system, and what we saw about the deaths and the morbidity associated with the current system related to scheduling and pharmacy. So knowing that there might be something else, allied health, specialties, whatever, that is core competency of any EHR. How could that have broken down?
Yeah, that is, the pharmacy process, as you may know, at VA is different than it is in all of private medicine and in the DoD. That said, it is an obligation to deliver those features. We did deliver those. The initial estimate when I first testified in front of this committee in July of last year was that it would take 3 years to fix the pharmacy issues. We delivered the top 3 issues in 4 months, and the next prioritized issue on the list will be delivered in April. So I think we've made material improvements in the pharmacy module here in the 9 months that we've been involved.
Well, thank you all for trying to make something good happen for the veterans, and I appreciate it. I yield.
Thank you.
Ms. Harris, let me confirm my understanding is that the GAO recommendation is for certain criteria to be met by the VA before there is a further expansion of the sites in which this system is to be utilized. Is that true?
Yes, that's true.
So what is the GAO recommendation in that regard?
To establish goals associated with user satisfaction and to have market improvement against those goals before continuing on with deployments.
And do you outline the nature of those goals?
Well, we do not outline the nature of the goals. I think that should be up to VA to establish what the appropriateness of those goals should be. And I think VA with Dr. Evans and Dr. Elnahal should be working very closely together to identify what the appropriateness of those goals should be. But what's important is that VA does this and that they measure against it. And before they do anything else in terms of proceeding forward with deployments, that they have significant improvements in their user satisfaction.
And is that the only criteria that, at least, let me say it, criteria in the sense, yes, the VA needs to determine the desired outcome. But user satisfaction, is there something more that you mentioned in your report?
There is. So that I would, in terms of priority, that is the most important priority, but also relative to change management as well. We made 7 specific recommendations on improving their organizational change management, and the VA should be implementing those and be in a better position before they continue on with deployments as well in that regard.
And the VA's response to those recommendations, that recommendation?
They did concur with all of our recommendations.
And the sense that they are following through, if they concur with your recommendations, then do I have the answer I was looking for earlier? If they concur with your recommendations, then there would be a pause. The answer to my question is yes.
That's what we're looking, that's TBD. I mean, from everything that I've heard now, it sounds like they will continue to proceed with deployments, but
And that's different than what you were told by the VA in response to your recommendations?
Well, they said that they concurred with the recommendations, but they did not provide specificity in terms of the timelines for implementing those recommendations. So I assume that they would take into account the pause and get back to us with timeframes for the new schedule for deployments once they've implemented those recommendations.
So, Dr. Elnall, what am I missing? Why is it difficult to say? I mean, we've heard from a number of my colleagues about the health consequences to veterans as a result of the utilization of the AHR system. I'm not sure I can understand why, if that is true, which seems to be the case, then if it is a matter of certainly health and welfare and perhaps life, then what would be the reason that it's difficult for you to say we're going to wait for criteria to be met, satisfaction, before we expand the number of hospitals, sites that are going to be utilizing this system?
I don't think you're missing anything, Senator. We concurred with that recommendation. I would want to see improvements in user satisfaction and adoption of this system before we deploy further. I just want to declare that.
Let me try the question
clearly.
then, and if you do not see that, then what?
Well, what we're doing now with Dr. Evans and his team is refreshing what we call the broader readiness criteria, apropos of Ms. Harris's and her team's recommendation to us to clarify those goals around readiness for deployment and beyond. So we're working on that now feverishly. And as we do that, site by site, we are going to assess readiness. And if we are not ready against those criteria, we will not go live at those sites.
So is the unknown at this moment the criteria?
We are refreshing that criteria. I'm interested in what Dr. Evans' perspective is as well, but we are refreshing that criteria as a team right now.
So the Department of Veterans Affairs comes up with criteria that they say today needs to be met before there's further expansion of the system. And the only, and if that criteria is not met, then the expansion would not occur. And the thing that we don't yet know today is what the exact criteria is. That a summary of what you are testifying?
Yes, Senator. There are obviously criteria that the program has used before. We paused deployments back in July at the Secretary's request. We extended that pause in October to do the sprint analysis. And now, of course, we have much more information about vulnerabilities in the system, things we needed to do in VHA to better prepare for the change management recommendations that Ms. Harris mentioned. So that criteria needs to be refreshed, and that's what we're doing right now.
And may I assume that what seemed, at least seemingly to me, was a reluctance to say there would be this delay if their criteria was not met? You're not concerned that if you said that then Cerner Oracle would be less intent on fulfilling its obligations under the contract?
We expect Oracle Cerner to follow through on our requirements.
Anything here, Mr.
You know, I think that obviously end user satisfaction is critically important. It's not just a contractual requirement; it's a moral requirement as well. Given the fact that these people are caring for our nation's veterans, I would say, in concert with Ms. Harris said, I think that end user surveys, it has to be paired with the change management process. If you just survey people and make that the only criteria, and you ask them, would you like to change? Usually, the answer is not positive, right? So in any kind of survey where change is associated, without a strong change management process accompanying it, you will inherently get more negative answers than positive answers. However, I will say that the feedback that I heard in Columbus was very pointed. It was very well formed. I think the people who are using this system have put a tremendous amount of thought into it. I think they know what they need to make it better, and I think we can deliver it. And I would say that the only feedback is just general surveys, and sometimes can backfire because without accompanying process around them, you know, you can survey forever before you get to the resumption.
Dr. Elnahal, your criteria is broader than just user satisfaction.
Yes, Senator, we have to consider everything from operational readiness of the facility, making sure that a certain number of employees were trained appropriately. We're working on revamping training, starting the training much further in advance of deployment, looking at specific user roles, tailoring to specific user roles. So there's a number of things we're doing with training. And yes, there are a good number of other criteria.
And I'll belabor this a while longer. The criteria that you are utilizing will be based upon outcomes from the places that the system is already deployed to determine whether to deploy it elsewhere.
In part, yes, especially user satisfaction. That's the only place where we'd be able to get that information. And with Block 8 and with some of the changes we've made since the beginning of the sprint, I do hope to see that users are saying more often that the system is meeting the needs for veterans.
And the places that the system is going to be deployed in the next series, what input or what criteria is required from them to determine whether to further deploy?
I mean, I think, yeah, I can, so I think.
I think this is my last question on this topic, and then I have one more.
Right. So, you know, we need to assess the readiness of the solution itself. That is its technical performance, the reliability, system response time, et cetera, and the configuration, whether it is meeting the needs, right? And so those are, and a piece of that leads to user satisfaction. As we've been talking about, we also need to assess the readiness of a site to engage in change. And so we will be focusing on improvements at existing sites, assessing satisfaction, and frankly, the system performance, the configuration changes that you've heard mentioned earlier that we can make to improve the path forward. That is critical, but as we look forward at future sites, we have to ask those same questions. And so the criteria will apply to both.
The 14 patient safety issues that have been identified, they should be fixed before further deployment? That's a question, not a statement.
Yes, we should have a clear and unambiguous plan and an assessment of what must be fixed before we go live. I would argue that our lean is that they should all be fixed. But remember, this system is in use right now. We have mitigations in place for existing sites. Ideally, we have them all fixed before we go live.
Dr. Elnahal, my last question, Mr. Chairman, although you made the mistake of telling me I could go as long as I wanted.
Yeah, well, the vote's about to close, but it's okay.
I don't think so, not quite yet. First of all, I'd compliment you in your political skills, despite the number of times your name was mispronounced. In every instance in which you were asked if it was being pronounced correctly, your answer was yes. I guess I shouldn't question your veracity based upon that evidence. Doctor, do we have your commitment that staff at existing Cerner EHR sites will make liberal use of their authorities under the Mission Act to refer veterans who might be worried about any of their safety or well-being to community providers until the improvements are made or until the best interest of the veteran is altered? I didn't ask my question very well. Let me try this again. I want to make sure that you're going to utilize community care as an alternative in regard to any veteran that may have concerns about the system.
Well, I'll start, Senator, by saying that I've been giving the benefit of the doubt in the pronunciation of my name since I was a child. On that question, absolutely. Where we are not able to meet the access standards, which are in place and something we adhere to, regardless of whether our facilities have Cerner or Vista, we offer community care. And we've seen increases in utilization of community care at the 5 sites because of decrements in productivity that you would expect after go live. We're seeing 1 facility reach pre-deployment productivity, but the 4 others have not. And you've seen across the board, and we've seen the community care utilization go up because we need to make sure that veterans get the care one way or the other.
Thank you for your answers. Thank you, Mr. Chairman.
I've got one more, too.
I gotta go.
Senator Moran, I figure you probably did, but that's okay if you need to go. I was looking down this committee. Many of the people on this committee are either in the Authorization Committee for the Department of Defense or an Appropriations Committee for the Department of Defense. Mr. Del Bene, in a recent interview, Secretary McDonough said, too often we're a downstream consumer of this infrastructure, and too often our concerns become secondary to, for example, the DoD, which manages big parts of this network, and this makes implementation of this system harder than it might be. Could you respond to that?
Thank you for the question. I support his statement there. I think this is a complicated system that has dependencies between the VA and the DoD. There are services that we consume from the DoD, such as login and patient safety or patient information exchange, that we've had issues around reliability, and we've been speaking to our peers at the DoD to try to get those resolved. But that's one area. And the other area, I think, is around getting us to a point of shared governance such that we manage the enclave together. I think it's just a matter of history that they started this deployment and then we've added on as kind of a second tenant. We need to get to a place where we share in all those kinds of decision-making, and we're working with them on that. But it is that, to what the Secretary said around the frustration that we sometimes have of, we think we need to go in this direction, how do we get that to be executed across the 2 organizations?
One of the solutions that we had to solve any kind of problems between the DoD and VA, because, by the way, turf is always a problem around this place, is a joint executive committee. Is it working?
I think we are able to bring issues to the JEC when they get raised. I think the problems are, as you say, in a very large organization, when we get down to the specifics of getting a particular issue resolved, it can sometimes get bogged down. And despite the best intentions of both sides to resolve those issues.
Okay. Last question, and this is your opinion. You've been in this business of technology your whole life. You've been in this position for a couple of years now?
15 months.
15 months. Time doesn't fly when you're having fun. But is this something that can be done before I get really old?
I do think it can be done. I was trying to figure out how not to speak about your age, but I do believe it can be done. I think that we're in a very different position than we were when we started this rollout. I think we've made great progress in the sites that have gone active, and we understand the issues, and we're driving the issues. I think there's a long road still to get to absolute perfection, but I think we're on that path. And so I do think it can be implemented and successfully for the benefit of our veterans.
Mike, Cecilia said a bit ago that the players that were in place were better. If I paraphrase this wrong, you correct me, were better now than they have been in the past. Fair statement, Mike?
I would say that's fair. I wouldn't say the other players were bad by any means, but
But
yeah,
they're better
I
now
think
than they have been in the
we've
past.
enjoyed
Perfect.
We've enjoyed more
Perfect.
collaboration.
Perfect. For you, since you're the IT guy, do we have the people in place to make this work from a VA perspective?
From a VA perspective, I definitely think we have the right people in place. I think our oversight of this project is strong. I think we are holding Oracle Cerner accountable for strong deployment, and I do think we have a good team in place to execute.
Then I would ask the same question to you, Mike, but I know your answer is going to be, we're going to have the right team come hell or high water, right?
Yes, sir. That's correct.
All right, let me close this out. I want to thank you all for being here today. This has been a good hearing, only if it results in progress, okay? If we're back here, even 3 months from now, still talking about the same old stuff, then we've got some issues. I think everybody up and down the rostrum made very, very good points about what the expectations are. And I think that it is driven by one thing, and that's making sure our veterans get the health care they've earned in a way that they deserve, okay? Status quo is unacceptable. I think we all know it, up and down the line. We're tired of excuses. We want to have results. And I would just say that if everybody puts their shoulder to the wheel and the wheel's going in the same direction, I have confidence. But I will tell you that my confidence has been waning. And so I really do want to see results. Thank you all for being here. This hearing is now adjourned.